gusto para nosotros tener a nuestra invitada de hoy, la doctora Jennifer Bennett, que es especialista en patología del Penn State Hartley Medical Center y quien actualmente trabaja en la Universidad de Chicago Medical Center. Estará como moderadora la doctora Heidi Ramírez. Recordamos que tenemos traducción simultánea. Allá abajo en sus pantallas donde dice, ahí aparecen los idiomas. Entonces, en este momento ustedes me están escuchando porque estamos en el canal de inglés. Cuando la doctora Jennifer empiece a hablar y los que quieran escuchar en español, entonces ponen el idioma español y inmediatamente escucharán a nuestra traductora. Recuerden que todos los webinars quedan grabados en el canal de YouTube de la Asociación Colombiana de Ginecólogos Oncólogos para que ustedes puedan acceder en cualquier momento para revisar cualquiera de los temas que se han presentado acá. Doctora Heidi, tiene la palabra.
Bueno, muy buenas noches. Como ya hizo la introducción la doctora Lucrecia, los invito a que por favor formulen durante la charla sus preguntas en el chat para al final de la conferencia de la doctora poderlas realizar. It's a pleasure to me to introduce you Dr. Jennifer Bennett, who received her medical degree from the University of Florida in Gainesville, Florida, and completed an anatomic pathology residence at Penn State Hershey Medical Center in Hershey, Pennsylvania. She was then the Robert E. Scully Fellow in Gynecologic Pathology at the Massachusetts General Hospital in Boston. After a few years in community practice, she re-entered academic medicine at the University of Chicago Medical Center in Chicago, Illinois, where she is currently an associate professor. Her research focuses on the integration of morphological, immunohistochemical, and molecular findings to better characterize gynecologic neoplasm, in particular uterine mesenquimal tumors. She has authored numerous articles on this topic and also co-authored several sections of the 2020 WHO Blue Book on female genital tumors. In her free time, she enjoys hiking and traveling. Dr. Bennett, the audience is yours. Thank you for being with us.
Thank you very much for the kind introduction. Can everyone see my screen?
Yes,
okay.
Yes.
Yes, okay. So my talk today is going to focus on updates in uterine mesenchymal neoplasms, those that were described either in the recently released WHO in 2020 or novel findings that have been introduced since that time. And I'm basically going to focus on the epithelioid and myxoid patterns of these tumors. I have nothing to disclose. So to begin with, this is the outline of the talk. I've chosen several examples of these tumors for both the epithelioid pattern and the myxoid pattern, which I'll go into more depth in momentarily. And at the end of each section, I'll do an overview that's by no means exhaustive, but other tumors that should be thought about in the differential diagnosis when you're presented with an epithelioid or a myxoid pattern. So beginning with the epithelioid pattern. So the three tumors I chose to focus on are smooth muscle tumors, PCOMAs, and the YWHAE NUDM2 high-grade endometrial stromal sarcoma. So we'll begin with the epithelioid smooth muscle tumor. So the first question is, what qualifies as an epithelioid smooth muscle tumor? Well, according to the WHO 2020, the tumor must consist of at least 50% of round or polygonal cells. The remainder can consist of your classic spindle cell component. These round or polygonal cells grow in either a nested, corded, nodular, or diffuse pattern, and the cells can have either eosinophilic or clear cytoplasm. So epithelioid smooth muscle tumors can be broken into three groups, just like your conventional spindle cell tumors, smooth muscle tumors. The three groups are epithelioid leiomyoma, stump or smooth muscle tumor of uncertain malignant potential, and leiomyosarcoma. And the key to getting the correct diagnosis is extensive sampling, because that'll greatly help in assisting the diagnosis. And for the purposes of this talk, I'm going to focus on epithelioid leiomyosarcomas, as the other two are exceedingly rare. So according to the WHO, an epithelioid leiomyosarcoma can be diagnosed when one or more of the following criteria are fulfilled. The tumor should have moderate to severe nuclear atypia or tumor cell necrosis, or greater than or equal to 4 mitoses per 10 high-power fields. However, recently the Brigham group in Boston looked at a series of 81 epithelioid smooth muscle tumors, which is the largest series of this tumor type to date. And they proposed modified criteria for diagnosing an epithelioid leiomyosarcoma. Instead of just one of the following criteria, as the WHO recommended, they proposed that to diagnose a tumor as epithelioid leiomyosarcoma, you should have 2 or more of the following criteria, which basically mirror that seen in the WHO. So greater than 2 plus nuclear atypia, greater than 4 mitoses per 10 high power fields, and or tumor cell necrosis. So here are some images of an epithelioid leiomyosarcoma. You can see here that we have these epithelioid cells growing in nested to a sheeted pattern, and they're quite atypical. And in the bottom 1/3 of the screen, we can see some conspicuous tumor cell necrosis. Here is a higher power image of an epithelioid leiomyosarcoma. You can see we have this very atypical mitotic figure up here and some tumor giant cells. And even more high power, you can see the moderate to severe nuclear atypia and brisk mitotic activity. And here is an example of a epithelioid leiomyosarcoma that has abundant eosinophilic cytoplasm as compared to the clear cytoplasm we saw in the prior images. So looking at ancillary studies, in these tumors, usually Desmond, SMA, and Cal-Desmond, your basic smooth muscle markers, are positive. However, the intensity and extent of staining can be variable. Your melanocytic markers are usually negative, or at most focally positive, which introduces our next topic, apicoma, since they are definitely morphologic mimickers, and we'll get to that momentarily. And only a handful of epithelioid leiomyosarcomas have been sequenced to date by next generation sequencing. And they show mutations that are very common to what you see in spindle cell or conventional leiomyosarcomas, such as ATRX, TP53, P10, and CDKN2A. So a few years ago, back in 2019, the Memorial Group in New York City identified a subset of epithelioid leiomyosarcomas that harbored PGR, or progestin receptor fusions. And so these tumors, the most common partner was NR4A3. The patients actually ended up presenting at a slightly younger age than your classic epithelioid leiomyosarcomas, being 45 years. And in contrast to many conventional epithelioid leiomyosarcomas, they have low stage disease, meaning either FIGO stage 1 or 2. And they can arise either in the cervical stroma or the myometrium. So these tumors consist of a high-grade but uniformly atypical component of epithelioid and or rhabdoid cells. There usually is an admixed spindle cell component that's of low to intermediate grade. And as I said before, they're uniformly atypical, so they lack the overt pleomorphism that we saw in the images previously. Their vasculature consists of small arterioles and the classic thick-walled vessels that we think about for smooth muscle tumors in general, and a handful of them might show a myxoid matrix. So here's an example of an epithelioid leiomyosarcoma with a PGR fusion. As you can see, the cells are atypical, but they're definitely not as atypical as what we saw previously. And you can see this dense eosinophilic cytoplasm imparting a rhabdoid appearance in these tumors. So the overall IHC profile for epithelioid leiomyosarcomas with PGR fusions is similar to that as the classic epithelioid leiomyosarcomas. You have positive desmin. However, the positivity is quite variable in the epithelioid or rhabdoid cells. In contrast to your classic epithelioid LMS, cal-desmin is often negative, and ER and PR are usually positive. And it's negative for other IHC markers that can be helpful in the differential diagnosis, such as CD10 helping to rule out an endometrial stromal neoplasm, HMB45 helping to rule out PCOMA, and myogenin helping to rule out a rhabdomyosarcoma. So next we'll move into PCOMA, since I've already have teased that topic a little bit. So PCOMAs arise from the mysterious perivascular epithelioid cell, or PEC, and no known normal counterpart of this cell has been described to date. PCOMAs are interesting in which they express both melanocytic and myogenic markers, and about 10% of them are associated with tuberous sclerosis complex. And there are two distinct molecular subgroups, which we'll talk about in a few moments. So here's a gross image of a PCOMA, or two gross images. On the left, you can see that we have this very necrotic fungating mass, while on the right, it's relatively well circumscribed with a white to pink cut surface. Under the microscope, these tumors consist of non-cohesive epithelioid cells, with or without a spindle cell component. Rarely is the spindle cell component the dominant portion of the tumor. They tend to grow in a nested or diffuse architecture with very delicate vessels surrounding those tumor cell nests. And their cytoplasm is often clear to eosinophilic and granular. So let's look at some images of these. So here's your classic PCOMA growing in this nested architecture with the delicate vessels encircling the tumor. The cells are very epithelioid or round, as we see here, and they have abundant clear to eosinophilic cytoplasm. Here's an example of a spindled component in a PCOMA. And on higher power, you can really see the clear and eosinophilic granular cytoplasm in these tumors. So it's clear here and eosinophilic and granular more surrounding the nucleus in this particular cell. Some of the nuclei may also show these nuclear inclusions. And on the right, we actually have a tumor where the cytoplasm is more eosinophilic. Some histologic features that you can see in uterine PCOMAs, but are not frequent, include melanin pigment, as seen on the left, and abundant vacuolated cytoplasm, as seen on the right. So this is what many people think about when you hear the term PCOMA. You can see these tumor cells that are just emanating from this blood vessel in the center of the screen. This is the perivascular or radial distribution of the tumor cells and where they get their name of perivascular epithelioid cell tumor. You can see this in about 20% of PCOMAs, but the thing is, it is not a pathognomonic finding, as I have seen it in a handful of smooth muscle tumors as well. So this feature should be interpreted with caution. PCOMAs may occasionally have this very extensive hyalinized or sclerotic matrix. And in these circumstances, it can be diagnosed as a sclerosing PCOMA. These tumors are quite uncommon in the uterus. They're more frequently seen in the retroperitoneum, but they have been reported in the uterus. So this is a recent review article that was published earlier this year. that I co-authored with one of my mentors. And we looked at all the major studies of PCOMAs and looked at their immunoprofiles. And as you can see here, almost all tumors are positive for HMB45, which is a melanocytic marker. And the majority are also positive for MITE-F. Melon A, also a melanocytic marker, is positive about 2/3. But what's important to note is SMA, Desmond, and Cow-Desmond, all smooth muscle markers, are expressed in the majority of PCOMAs, which definitely raises the differential with a smooth muscle tumor. So this is our recent study that's in press where we looked at a handful of uterine PCOMAs to characterize their molecular profile. And as expected, since a handful of these tumors are associated with tuberous sclerosis, these, even the somatic version of PCOMA does harbor mutations in either TSC1 or TSC2. And as you can see on the left with the gene names here, we have very few other mutations that were identified in uterine PCOMAs. So the first subgroup of uterine PCOMAs is those that are characterized by the TSC mutations. And those are the ones I like to call the classic PCOMAs. They're more common, as much as you can say common for a relatively rare neoplasm. But they're definitely more common compared to the TFE3 translocation associated PCOMA, which is the second molecular group that's characterized by TFE3 fusions. These do not show any alterations in the TSC proteins or genes. So TFE3 translocation associated PCOMAs tend to have a very characteristic morphology. They consist of these epithelioid cells with extremely clear cytoplasm that grow in a nested or alveolar architecture. They are usually strongly and diffusely positive for HMB45 and the protein TFE3, the antibody TFE3. However, MITE-F, the melanocytic marker, and other myogenic markers, the smooth muscle markers, are typically negative. So here's a photomicrograph of a PCOMA. You can see these clear epithelioid cells with abundant clear cytoplasm growing in this nested architecture. And the inset here shows strong and diffuse TFE3 staining. So there have been several algorithms that have been proposed looking at variable clinical pathologic features to predict the behavior of PCOMAs. And you can see the first one here was by Folpe and colleagues in 2005. They looked at both soft tissue and GYN PCOMAs. Schoolmeister in 2014 only looked at GYN PCOMAs. And then in our initial PCOMA study, we once again only looked at GYN PCOMAs, particularly those in the corpus or cervix. And so each algorithm has been slightly modified. And the current one that, the most recent one that was done by my group showed, was later adopted by the WHO. So it just looks at a number of histologic features to determine if it's going to act in a uncertain malignant potential or malignant potential. So here's an example of a malignant PCOMA. You can see this pink material indicative of tumor cell necrosis. The cells are very atypical. There's brisk mitotic activity. So by the algorithm, this was designated as a malignant PCOMA, and the patient did have an adverse prognosis. In our recent study that I mentioned previously, looking at the molecular profile, we also saw that our 6 malignant PCOMAs, 5 out of the 6 of them harbored mutations in either TP53, ATRX, or RB1, and these alterations were not identified in any of the tumors that acted in a benign fashion or uncertain malignant potential, as we have deemed them to be with the 2-category system as opposed to a 3-category system. So these next generation sequencing findings can potentially be used as a useful adjunct to the morphological based algorithm to predict behavior of these tumors. However, results are limited and more studies are definitely needed. So this is just a brief table comparing the major immunohistochemical and molecular findings between PCOMAs and epithelioid smooth muscle tumors, because as I'm sure you know, these tumors definitely morphologically mimic each other. So PCOMAs are typically positive, usually at least 50% of the tumor is positive for HMB45, whereas epithelioid smooth muscle tumors are either focally positive or negative. Melon A and MIDAF, although they're positive in the majority of PCOMAs, their amount of expression and intensity of staining is very variable, whereas they're focally positive or negative in epithelioid smooth muscle tumors. Myogenic markers such as SMA, Desmond, and Cow-Desmond don't help that much since they're often positive in both groups of tumors. TSC alterations are frequent in PCOMAs, but not yet reported in epithelioid smooth muscle tumors, whereas TFE3 fusions are seen in a small subset of PCOMAs, not in epithelioid smooth muscle tumors, and the inverse for PGR fusions. So that probably still leaves you quite confused because it basically looks like the morphology and IHC definitely overlap. So in a nutshell, what is my method for diagnosing these tumors on the rare occasion that I actually receive one? Well, after performing a thorough morphological and immunohistochemical evaluation, if I can't make a definitive diagnosis, I would just sign out the tumor descriptively for those that look relatively, oh, sorry about that, my light just goes off if I don't move. If those that look relatively bland, I would just say something like a low-grade epithelioid mesenchymal neoplasm with myomelanocytic expression, and then discuss the differential in the diagnosis in the comments. And you don't necessarily have to do molecular testing since it definitely is not easily accessible in many locations and can be quite costly to the patient. So I would personally only recommend genetic testing if the patient has metastatic or recurrent disease at diagnosis, or metastatic disease at diagnosis or a recurrence, because these tumors can have TSC mutations. You don't want to miss the opportunity to treat with an mTOR inhibitor. Plus, I would also make sure that a extensive clinical and family history is taken, just because you don't want to miss a potential tuberous sclerosis diagnosis, even though, of course, it's quite uncommon in the majority of PCOMAs. So finally, ending the epithelioid pattern, we will focus on the YWHAE NUT-M2A/B high-grade ESS. These are formerly known as the YWHAE FAM or YFAM high-grade ESSs. So this is the current classification of endometrial stromal neoplasia in the WHO 2020. So we have your endometrial stromal nodule, your low-grade ESS, typically characterized by JASF1 or PHF1 fusions, your high-grade ESS, and then your undifferentiated uterine sarcoma. I know this can be quite confusing because it seems like with every version of the WHO, the classification of these tumors keeps changing. So it's definitely an evolving area. So looking more closely at high-grade ESS, we had the YWHAE ones, we had the B-core related ones that I'll discuss in the myxoid pattern, and then we have those rare tumors that look low-grade but have areas that have increased nuclear atypia or mitotic activity and tend to act in a aggressive fashion. Those are called high-grade transformation, or considered high-grade transformation of a low-grade ESS. So the YWHAE tumors, they consist of a high-grade round cell component. It has that classic small round blue cell appearance. Mitoses are brisk. Tumor cell necrosis and lymphovascular invasion are common. And about 50% have that low-grade fibroblastic or fibromyxoid spindle cell component that looks like a low-grade ESS. And their vessels are characterized by a delicate network of arborizing or curvilinear vessels. So here's an example of the small round blue cell component of a YWHAE NUDM 2A/B. That's a mouthful. High-grade ESS. You can see the small round blue cells and then those delicate curvilinear vessels surrounding the epithelioid cells. Higher power, you can see the brisk mitotic activity. And here is an example of the low-grade spindle cell component that looks like a low-grade ESS. So under using IHC, there is some differences between the high-grade and the low-grade component. The high-grade component is typically strongly and diffusely positive for cyclin D1 and B core, whereas they're focal or negative or even variable in the low-grade component. c-KIT or CD117 shows strong membranous and cytoplasmic staining in the high-grade component and weak or negative staining in the low-grade. CD10, ER, and PR are all negative in the high-grade, whereas they're strongly and diffusely positive in the low-grade component. And smooth muscle markers are typically negative in both components, unless, of course, a smooth muscle metaplasia is present in the tumor. So finally, I'll end with other tumors that may have an epithelioid pattern that should always be considered in the differential. You have your undifferentiated or dedifferentiated carcinoma, the recently described SMARCA4 deficient uterine sarcoma, uterine tumor resembling ovarian sex cord tumor or uterus, your high-grade ESS with B-core internal tandem duplication that we'll talk about in the next section, a rhabdomyosarcoma, and then of course, things you never want to miss, a lymphoma, plasmacytoma, melanoma, or metastasis. So moving on to those in the, moving on to the myxoid pattern. So the three tumors I chose to focus on are the smooth muscle tumors, inflammatory myofibroblastic tumors or IMTs, and the B-core related high-grade ESS, which can be divided into two groups, the B-core rearranged tumors, those are the ones with the B-core fusions, or the B-core internal tandem duplication or ITD. So the first question that we always want to think about is how do we differentiate between edema versus myxoid material? Well, the unofficial way is on gross examination to use the squeeze test. And basically what you do is you take your tumor and you squeeze it, and if abundant watery fluid is extruded, that's consistent with edema. However, it's more gelatinous, clumpy, you start thinking about a myxoid tumor. Of course, that's just something that we don't really do that much, but always something to think about. The more scientific way would be to perform a special stain for Alcian blue at a pH of 2.5. And if it's negative, it's consistent with edema. If it's positive, it's consistent with myxoid. So starting off with myxoid smooth muscle tumors. So what qualifies as a myxoid smooth muscle tumor? According to the WHO, there really isn't any correct percentage. They just say that abundant myxoid stroma should be present in the tumors. However, the unofficial criteria is a 50% cutoff of the myxoid material, or at least 50% is recommended to designate a tumor as a myxoid smooth muscle tumor. So just like epithelioid and conventional spindle cell smooth muscle tumors, they can be divided into leiomyomas, stump, and leiomyosarcomas. And once again, extensive sampling is the key to diagnosis. And we will just focus on myxoid leiomyosarc since the other two are exceedingly rare. So according to the WHO, you can diagnose a myxoid leiomyosarcoma if you fulfill one or more of the following criteria: moderate to severe atypia, tumor cell necrosis, greater than 1 mitosis per 10 high power field, or if you see an infiltrated border or regular margin of the tumor. So it's definitely a lot, the criteria are a lot more lax to diagnose a myxoid leiomyosarcoma compared to a conventional spindle cell leiomyosarcoma. So here is a low power view of a myxoid leiomyosarcoma. Of course, we really can't see the architecture or the cytology here, but you can see it has this very infiltrative or irregular border. Higher power, you can see that we have this abundant myxoid material. And even higher, you can see that we have these relatively bland, there may be some mild to moderate atypia, these elongated nuclei that are consistent with the cigar-shaped nuclei that you would expect for a smooth muscle tumor. By IHC, there aren't really any general consensus for the for staining for smooth muscle markers because it has been changing over the years. In the past, smooth muscle markers were most commonly negative or very weak or patchy in myxoid leiomyosarcomas, but more recent studies have shown that that most tumors are positive for at least one, if not multiple, smooth muscle markers, and they can be more stronger and more diffuse than originally anticipated. And also CD10 is important to do, or well, is important to interpret correctly because CD10 can be positive in greater than 2/3 of myxoid smooth muscle tumors. So you don't want to over or misinterpret it as a endometrial stromal tumor. P53 and P16 are not really that helpful because they both can show aberrant expression in 50% of tumors. And of course, many other high-grade sarcomas can show aberrant expression for these markers. PLAG1 is a novel immunostain that has recently been described in a number of myxoid leiomyosarcomas, and we'll talk about in a minute how a subset of myxoid leiomyosarcomas show PLAG1 fusions. However, PLAG1 IHC can be positive even in the absence of a PLAG1 fusion. B-core is somewhat helpful because although there's a subset that are positive, they're often weaker focal compared to high-grade ESS that have B-core internal tandem duplications. And then importantly, ALK and ROS1 markers of inflammatory myofibroblastic tumors are negative in myxoid leiomyosarcomas. So as I said, a subset, about a quarter, harbor PLAG1 rearrangements, but of course, the number of tumors that have been sequenced to date in studies is exceedingly low. But overall, these tumors lack prevalent driver mutations and fusions. They have a low tumor mutational burden, but they do have a large number of copy number variants. Really nothing specific aside from the PLAG1 that has been identified thus far. So moving on to inflammatory myofibroblastic tumors. So these were first described in 1987 by the Vancouver group. And at that time, they were termed inflammatory pseudotumor of the uterus. And it wasn't until 18 years later that the first larger series of these tumors was described by the UCSF group. And in their series, they believed that all of these had a benign clinical outcome. However, unfortunately, we have found with more studies that this is not true, and a subset do have malignant potential. So here's some gross images of a inflammatory myofibroblastic tumor. Unfortunately, the tumor on the left was more isolated, but you can see it has this gelatinous tan brown cut surface, and the tumor on the right is kind of nodular with areas of necrosis. Under the microscope, they have 3 architectural patterns. You may or may not see all 3 patterns, or you might only see one. The 3 main patterns are myxoid, compact fascicular, or hyalinized. They tend to have lymphoplasmacytic inflammation. However, the amount of inflammation is variable among tumors, with some having very little and some having a lot exuberant inflammation, and the cells are typically spindled. So here's a low power appearance of a classic inflammatory myofibroblastic tumor. You can see this myxoid matrix that these relatively low grade spindle cells are percolating throughout. Here's an example of the compact or fascicular pattern. As you can see, it definitely just looks like a leiomyoma. I mean, if this is all that came across my microscope, I probably would sign it out as a leiomyoma and not even think twice, because it looks classic for a leiomyoma under the microscope. So it's important to sample these tumors adequately. And then finally, here's the hyalinized pattern. It looks like a scar on the right side of the screen. The hyalinized pattern usually is, if it's present, it's only present in a low percentage of the tumor, like 5% at most. Here's a tumor that had exuberant lymphoplasmacytic inflammation. As you can see, all the lymphocytes here, and there are some plasma cells percolating through as well. But as I said, sometimes inflammation can be very focal. So the majority of uterine IMTs are positive for the ALK immunostain. And as you can see here, it shows this very nice cytoplasmic and granular staining pattern. Aside from ALK IHC staining, they are positive for many smooth muscle markers. So of course, that causes a dilemma with, is this just a myxoid smooth muscle tumor, or could it be something else? It's variable, but up to even 100% of tumors in one study can be positive for CD10, which then of course raises the differential with an endometrial stromal neoplasm. IFID-M1, which is touted to be a more sensitive and specific marker for endometrial stromal cells, actually is positive in these tumors as well. So that's not helpful in the differential. And B-core can be somewhat helpful, but it can be weak or focally positive in a subset of IMTs. So you don't necessarily need to do molecular testing, either FISH, fluorescence in situ hybridization, or some sort of RNA sequencing fusion analysis to diagnose an IMT. A lot of times it can be an easy easy morphologic diagnosis, and IHC for ALK normally seals the diagnosis. But in some morphologically ambiguous cases, or if a patient has metastatic disease at diagnosis or has recurrence, it might be helpful to perform the ancillary molecular techniques. And I'll talk about why in a moment. So fluorescence in situ hybridization, or FISH, it uses a break apart probe. So as we can see here, this is positive for an ALK fusion because you have a split red and green signal. However, there is a pitfall with FISH because you can get a false negative result if an intrachromosomal inversion is present, meaning if the partner gene for ALK is on the same chromosome as ALK, the signal may not be split wide enough that you can see it under the fluorescent microscope. So another method that can be used is RNA fusion analysis. These are some partner genes that have been identified to date. However, just like FISH, there is a pitfall. If the entire ALK gene is not sequenced, it can result in a false negative result, because fusions can occur outside of these specific exons for uterine IMTs. And these are the exons that are most commonly covered in most commercial RNA sequencing panels, because this is what you see for lung carcinomas with ALK fusions. So those are, of course, a lot more common than inflammatory myofibroblastic tumors. So just something to consider. So I've talked a lot about ALK fusions and IMTs. Outside of the GYN tract, ALK fusions account for approximately 50% of IMTs, and the rest consists of genes such as RED, ROS1, and NTRK3. However, in the GYN tract, the majority are all ALK fused IMTs. There's been rare reports of the other ones, but they're exceedingly rare compared to the number of ALK rearranged IMTs that have been reported. So IMTs can occur in pregnancy. And when they do so, you can see the tumor has this very decidualized appearance, which is what you would expect with the increased hormone levels. They also tend to be strongly positive for PR, progestin receptor, by IHC staining. And many of those that have been sequenced are characterized by ALK fusions with TIMP3 or THBS1, both of which are genes that are involved in endometrial remodeling. And finally, as I mentioned earlier, a subset of malignant IMTs do have malignant potential. Of course, it's easy to determine in some cases if the tumor will act aggressively, like when you have these extremely large atypical nuclei with prominent nucleoli, and I'm sure elsewhere in the tumor there's a lot of mitotic activity, and here in the inset you can see LVI. So features like this, it's relatively well known that the tumor is probably going to behave aggressively. But unfortunately, histologically banal ones have occurred. So that's the question that many people are pondering on, is how do we identify these tumors that are histologically bland but can recur. One review article suggested a number of clinical pathological features to say that these tumors had an increased risk of malignant behavior. However, nothing is set in stone. And as I said, histologically banal ones have recurred. In our recent series where we looked at a handful of inflammatory myofibroblastic tumors and stained them for variable IHC stains, we found that 4 out of 5 of our tumors with complete loss of P16 staining, which is the gene, the protein encoded by the CDKN2A gene. 4 out of 5 of them had aggressive behavior. The 5th patient was lost to follow-up, so we do not know what happened with her. But perhaps this could be used as a helpful adjunct to morphology in the future. And we actually had NGS data on 2 of these tumors, and both of them had CDKN2A deletions. However, numbers are small and more studies need to be performed. And one tumor that acted in aggressive fashion harbored a TP53 mutation in addition to an ALK fusion. So while this really hasn't been described outside of abstract form, it's still something to consider. So a few questions. Is it merely academic interest to distinguish IMTs from other myxoid mesenchymal tumors? And it's actually not, because metastatic and or recurrent IMTs may be amenable to targeted therapy with tyrosine kinase inhibitors. So that's always something important to remember. And the next question that might have come across your mind is, I have an ALK positive tumor, morphologically looks like an IMT. Do I need to do molecular testing? Confirmatory molecular testing, in my opinion, is not necessary, since ALK IHC is very sensitive and specific. However, I don't know how it's done in Colombia, but in the US, a lot of clinicians may request confirmatory molecular testing in order to place the patient on targeted therapy with ALK inhibitors. So finally, moving on to the B-core altered high-grade ESS. We'll start out with those with B-core fusions. So here is an example of a B-core rearranged endometrial stromal sarcoma, or high-grade endometrial stromal sarcoma. You can see this exophytic mass arising from the endometrium. And these tumors consist of haphazard fascicles of spindle cells that percolate throughout a variable amount of myxoid stroma. Mitoses are typically brisk. They do not show a low-grade component, as we talked about, for about 50% of the high-grade ESS with the YWHAE fusion. And infarct-type necrosis is much more common than tumor cell necrosis. So here's an example of a B-core fusion, high-grade ESS. You can see it has that characteristic tongue-like pattern of invasion seen in endometrial stromal neoplasms. Higher power, we can see this abundant myxoid matrix and these kind of moderately atypical spindle cells. The arterioles are prominent in these tumors, but unlike low-grade ESS, which I know I didn't talk about today, but in low-grade ESS, the tumor cells typically whirl around the arterioles. You don't see that characteristic whirling in the high-grade ESS with B-core fusions. And then just an example showing the brisk mitotic activity in these tumors. So this is a relatively recent development. So the IHC profile still needs to be tweaked since only a handful of cases have been reported in the literature, but the tumors are typically positive for CD10 and cyclin D1. B-core, interestingly, even though they all harbor B-core fusions, it is actually only diffusely positive in 50% of tumors. And it doesn't correlate with the fusion partner as to whether the tumor will be positive for B-core IHC or negative. So the B-core IHC is typically strongly and diffusely positive in those 50% of tumors. However, one tumor with a B-core fusion did show weak and diffuse staining. So most smooth muscle markers are negative. However, SMA can be focally positive in about 30%. ER and PR is positive in a small subset, and they are negative for ALK, which helps to rule out a inflammatory myofibroblastic tumor. So the most common gene partner for these tumors is the C3H7B. Other gene partners have been described, but they're very infrequent. Other molecular findings you can see is activation of the cyclin D1 CDK4 kinase pathway in 65% of tumors, and MDM2 amplification has been reported in anywhere from 45 to 100% of tumors. And it's important to note for these last two, since you can have, there is targeted therapy with MDM2 inhibitors and CDK4 inhibitors. But of course, that's all more on a, those are all more clinical trial type based treatments. So finally, we'll discuss the other type of B-core altered high-grade ESS. These are the ones with internal tandem duplications, or ITD. So these tumors consist of three morphologic patterns. You have a high-grade round cell component, a high-grade spindle cell component, and a low-grade spindle cell component. And you also have the variable amounts of myxoid stroma and the brisk mitotic activity. So here's an example of the high-grade round cell component. You can see it looks very similar to the high-grade round cell component in the YWHAE high-grade ESSs. However, you tend to have more myxoid matrix in the B-core ones. And you can see the brisk mitoses here. Here's the high-grade spindle cell component, and you can see the cells percolating throughout the myxoid matrix. And finally, here's the low-grade spindle cell component, which looks like a low-grade ESS. And you can even see that characteristic whirling around the arterioles in this particular slide. So even less is known about the IHC profiles of these because a very low number of tumors, I believe probably like less than 20, have been described. They are all strongly and diffusely positive for B-core, unlike those with fusions where only 50% are positive. Cyclin D1 also is strongly and diffusely positive. And then CD10 is usually only focal, and Desmond can be positive up to 60%, same, and ER for 50%, and SMA and CalDesmond are negative. Molecularly, they harbor internal tandem duplications of exon 15 for B-core. You do not have that MDM2 CDK4 amplification that you see in the B-core fusion tumors. However, up to 20% do have deletions in CDKN2A/B. So here is a table showing the main highlighting the main differences between the B-core fusion and B-core ITD tumors. I touched on most of this, but one thing I did want to point out is that patients with B-core ITD tend to occur at an earlier age than those with the B-core fusions. And as you can see here, the median age is 44, which is 10 years less than the median age for B-core fusion tumors. And other tumors that should always be considered when you have a myxoid pattern of a tumor in the uterus include a low-grade ESS, the myxoid or fibromyxoid variant. Of course, you want to sample that broadly to make sure you're not missing a high-grade component. Once again, undifferentiated and dedifferentiated carcinomas can occasionally show some focal myxoid chains. As I mentioned previously, epithelioid leiomyosarcoma with PGR fusion occasionally has a myxoid change. Then something on the benign spectrum that can be misconstrued as a malignant tumor, apoplectic leiomyomas, because they tend to have high mitotic activity. And these are typically seen in younger patients on progestin therapy. And then, of course, carcinosarcoma and myxoid liposarcomas and other soft tissue sarcomas, but these are, of course, very exceedingly rare in the GYN tract. So, muchas gracias, and hay preguntas?
Thank you, Dr. Bennett, for this amazing update. Yes, we have some questions. One of them is, how often are these inflammatory mesenquimal tumors?
I'm sorry, how
often? How often do you see this IMT?
Oh, IMTs are relatively rare, although in the last couple months here, we've seen about 3 in our routine practice. So it's kind of definitely go in spells.
Okay. It's possible that our pathologists could be confused with hyalinase degeneration with these tumors.
Like are they just asking difference between hyalinization and like myxoid change? And
yes.
I'm assuming, yeah. So, I mean, normally it's quite. The myxoid change tends to be bluer. I mean, of course, it all depends on your H&E staining, the quality of it, since that can vary among institutions. But I mean, you can always, if you're concerned about myxoid material, you can always do an Alcian blue special stain, and it should be strongly positive. It should be blue in myxoid tumors, or myxoid matrix, whereas in the degenerative ones, it should, and edema, hyalinization, et cetera, it should be just, you shouldn't see any blue staining.
Okay. All these tumors or all these mesenquimal tumors are very rare in our practice, and are very difficult to diagnose, not only for you, also for us. It's difficult to trying to do a preoperative diagnosis. Do you think could be useful frozen section in these tumors?
I do not think frozen section is useful for any sort of mesenchymal tumors, even like differentiating between a leiomyoma versus leiomyosarcoma, because you really need to do extensive sampling of these tumors. I mean, of course, if the tumor looks very atypical on gross examination, most likely under the microscope if you were to do a frozen, you'd see like the high mitotic activity and the very atypical nuclei and maybe even some necrosis. But unless you see classic features for like a leiomyosarcoma or other type of high-grade sarcoma, I definitely would not say much more than spindle cell neoplasm defer to permanence, or epithelioid cell neoplasm if it was more of a pecoma versus epithelioid smooth muscle tumor situation.
Okay. Another question from our audience is, what should be your advice when a stump tumor is diagnosed in a myomectomy, immediate hysterectomy, or surveillance? and how long should be done this surveillance?
Well, I can't speak too much on this since I only practice pathology and not clinical OBGYN. I think it would really depend on, you really want to make sure that the pathologist had sampled the tumor very well to get to the diagnosis of stump, because a lot of times just doing additional sectioning can help point you towards a benign or a malignant diagnosis. Unfortunately, there isn't any special stain that you can do that'll automatically tell you, oh, this is benign or this is malignant. But I think we've had several stumps here, and I think for the majority, the clinicians just tend to follow, especially if they're younger patients who want to preserve fertility. But I definitely think it's a discussion between the clinician and the patient.
Okay. Which is your opinion about the P53 and the P16 overexpression in stump tumors?
Well, that can be challenging because although they can be overexpressed, they also can be overexpressed in leiomyomas with bizarre nuclei, which if you look at on low power with a very atypical nuclei, that would initially give you a false impression that you have a malignant tumor. So it's really important to do, as I mentioned multiple times, extensive sampling of these tumors. And I typically don't do any type of IHC staining if I'm trying to distinguish between a leiomyoma versus stump versus leiomyosarcoma. I tend to focus more on only doing IHC if I'm trying to determine the lineage of the tumor.
Okay, we have another question. Do you think CD10 it's the only immunohistochemical useful in these tumors? Is it more useful tool?
It's relatively useful distinguishing between a smooth muscle and a stromal neoplasm, because most smooth muscle tumors are negative for CD10 or else focally positive, and endometrial stromal tumors should not be strongly positive for smooth muscle markers, so that can help you narrow it down. But I do not find it useful in distinguishing between like an IMT and say a B core neoplasm or even IMT. Yeah, basically IMT. Yeah. Maybe, and PCOMAs, I do not think CD10 has been extensively studied, but for the most part, they are not a morphological mimicker of an endometrial stromal tumor.
Okay. And what is your recommendation for proliferation index measurement using MIB1 or Ki-67?
So I don't tend to use that stain really, because even areas of degeneration can show increased mitotic activity because it's a reactive process. So I typically do not use that stain because I don't find it that helpful. For me, really, the only time I use Ki-67 is if I'm trying to determine if something is a stick or serous tubal intraepithelial carcinoma of the fallopian tube. But I don't tend to use it in my workup for mesenchymal neoplasms. I know other people do, but that's just the way I was trained and what I've read throughout the literature since I've been on my own.
Okay, and finally, knowing that this is those are very rare tumors and make us a really problem to find the best treatment for our patients. Is there any clue in the intraoperative assessment? Is there any advice that you can give us as surgeons or to our pathologists trying to identify in the best way these tumors?
I mean, not many other things. I'm trying to think of the best way to say this. I mean, just doing intraoperative assessment, I'm not that fond of, as we touched about upon for the prior question. But I mean, I think really you just need to do extensive sampling and look at it under the microscope. I think that's the best way for pathologists to be able to make the diagnosis and for clinicians to know how to best treat the patient if it is something malignant.
Dr. Bennett, thank you so much for your nice lecture. This is a very interesting topic, very useful, and we are really glad to have you here.
Thank you very much.
You are officially invited to visit us. Come to Colombia, please.
I would love to once we can travel more again.
Yes.
Okay.
A todos ustedes, muchísimas gracias por su participación en la charla del día de hoy.
Muchas gracias, doctora Jennifer Bennett. De verdad, nos encantó su colaboración con nosotros. Yo pienso que aprendimos muchísimo. Para los clínicos son temas difíciles de entender, pero creo que aprendimos muchísimo hoy. Recuerden que esta charla queda grabada en nuestro canal de YouTube de la Asociación Colombiana de Ginecólogos Oncólogos. Les agradecemos mucho su asistencia a todos y a habernos acompañado durante todo este año en los webinars que hemos realizado y esperamos el año entrante continuar contando con la presencia de todos ustedes. Thank you, Dr. Bennett. We are very, very honored to have you today. Bye.
Thank you.
Bueno, buena noche para todos.